Good morning, everyone. My name's Stephen Atherton. I'm here to discuss the intricacies of major depressive disorder, with the desire at the end of this seminar that each of you leave here better equipped as physicians to assist patients diagnosed with this disorder, with some time at the end dedicated to the risks of trusting artificial intelligence while assisting patients, as it is such a hot topic in our culture currently. To start our time this morning, we will discuss the neurotransmitter theory associated with MDD. The neurotransmitter theory of major depressive disorder states that imbalances or dysfunctions in neurotransmitter systems, particularly those involving serotonin, norepinephrine, and dopamine, contribute to the development and maintenance of MDD. This theory suggests that depression may be linked to either low levels or reduced activity of these neurotransmitters or abnormalities in the receptor sites. From this understanding, we can see how these neurotransmitters discussed are affected by the medications prescribed for this disorder. Major depressive disorder medications primarily target neurotransmitters involved in mood regulations, including serotonin, norepinephrine, and dopamine, as discussed previously. Medications like selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors work by increasing the availability of these neurotransmitters in the brain's synaptic cleft, leading to improved mood and symptom relief. Other neurotransmitters like GABA and glutamate are also implicated in depression and may be indirectly affected by some antidepressant medications. From this, an important question must be asked. Even if medications are available, should they be prescribed to all patients? A risk-benefit analysis for treating major depressive disorder with medication involves weighing the potential benefits of antidepressant therapy against the associated risks. While antidepressants can be effective in reducing depressive symptoms and suicidal ideation, in the long term, they also carry risks, particularly in young adults, including an increased risk of suicidal thoughts and behaviors, especially when starting or changing doses. Each individual diagnosed with MDD should be evaluated on a case-by-case basis to ensure the benefits outweigh the risks regarding the prescribing of medications. Considering the risk-benefit analysis, the next step would be a breakdown of the associated issues and rates of success for common MDD medications. While many people with major depressive disorder experience significant symptom reduction with antidepressant medications like SSRIs, SNRIs, and bupropion, success rates vary and side effects are common. Approximately 70 to 80% of individuals see a significant reduction in symptoms with treatment, but up to 50% may not respond to the initial medication trial. Common side effects include nausea, weight gain, sexual problems, and sleep disturbances. And serious side effects include suicidal thoughts and behaviors, which can also occur among younger adults. As seen, a substantial portion of patients do not respond to these medications, and even when they do, side effects can lead to noncompliance or worsened outcomes. Mortality associated with prescribed medication use for MDD is a serious issue, particularly when MDD is combined with other conditions like substance abuse disorders, with suicide being the most common reason for this mortality rate. With all this information presented, there could be the tendency to see that the risk outweighs the benefit and that medication should simply not be involved. However, that's not the case, which makes MDD more difficult to treat. Untreated major depressive disorder is a chronic recurrent illness with a natural course of variable length and a significant risk of recurrence. While some individuals experience spontaneous recovery, the rate of remission without treatment is lower than with treatment, as stated previously. Untreated MDD is also associated with higher mortality rate, primarily due to suicide and other factors, including increased risk of physical health issues. This brings me to full circle to the original thought that each patient diagnosed with MDD is unique and should be treated according to who they are versus a streamlined treatment program. As stated at the beginning of the seminar, I'm going to take time to evaluate the differentiation between AI and typical breakdown of research. And even though AI produces a detailed list of the treatment options available regarding MDD, there's glaring differences between the presented research and AI's breakdown. The most glaring of the differences would be the lack of humanity associated with it, which this might seem like an obvious assessment as there's no humanity behind it. But when details are observed, it becomes clearer. AI focuses on the hard facts of therapy, including the different types of talk therapy, such as cognitive behavioral therapy. Still, there's a lack of support systems necessary to assist the individual moving forward. Family and friends are a vital part of the therapy process for an individual with MDD. The support of family and friends helps shift the tide when an individual is dealing with a depressive state and is unable to think clearly, helping remind them of the truths and the reality they may be missing. Even suicidal thoughts can be negated when there's a support system present. AI misses this in its analysis, and AI also misses the main point in this lecture that every individual is different, and several elements must be looked into before treatment is conducted. There should never be a blanket approach, but a unique, tailored approach to each patient seen. Thank you for your time this morning. I hope this presentation has been helpful as you move forward working with MDD patients.